Welcome to Kanski lecture series Cornea part 19, and in this part we are going to discuss about the metabolic keratopathies. These are the keratopathies that are having a problem with the metabolism in the cornea. So let's get started. Cystinosis. Cystinosis is a rare autosomal recessive gene, CTNS, lysosomal storage disorder characterized by the widespread tissue deposition of the cystine crystals, leading to a pediatric renal failure and a range of other severe systemic problems. So, what is this saying? That there is a problem in the lysosomal storage diseases, and there is a gene CS cysteine TN gene that is CTNS gene that is involved in this, and there is a deposition of the cysteine in different tissue material, especially in the kidneys, that leads to a pediatric renal failure. Non-nephropathic ocular nephropathic and intermediate forms can occur. Keratopathy may develop in the first year with progressive deposition of crystals in the cornea and conjunctiva associated with photophobia, epithelial erosion, and visual impairment. So there are different types that can occur with cystinosis. It can be ocular, it can be non-ocular, and nephropathic, that is basically nephropathic, and non-nephropathic, which is basically ocular, and it can be intermediate. Basically, there is a deposition of the cystine crystals in the cornea, in the conjunctiva, and it can cause epithelial erosions and visual impairment. Systemic treatment is with cysteamine, which can be given in eye drops form to reverse the corneal crystal formation. Figure 7.66a, you can see the small amount of the crystals that can be present in it. Next is mucopolysaccharidosis. The mucopolysaccharidosis MPS are a group of a lysosomal storage disorder involving enzyme dysfunction along the pathway for the breakdown of the glycosaminoglycans, long chain carbohydrate, formerly known as a mucopolysaccharide. So there is not a metabolism of the MPS, mucopolysaccharide. Basically, these are the long chain carbohydrates. Altered metabolites accumulate intracellularly in various tissue. Inheritance is mainly autosomal recessive. Systemic features vary with a type of MPS but can include facial coarseness, skeletal anomalies, heart diseases, and learning difficulties. So, what are the systemic involvement? Facial coarseness, skeletal anomalies, heart, and learning difficulties. Keratopathy comprises punctate corneal opacification and a diffuse stromal haze, figure 7.66b, and occur in all MPS except Hunter and Sanfilipino. So you have to remember in which cases it does not occur. Hunter and Sanfilipino, it doesn't occur keratopathy. Other ocular features may include pigmentary retinopathy and optic atrophy. So you can see figure B showing the typical appearance in mucopolysaccharidosis. There will be the stromal haze and there will be the punctate corneal opacities, and there can be pigmentary retinopathy and optic atrophy as well. Wilson disease. You know about the Wilson disease. There is an accumulation of the copper, and when the copper deposited, it can cause the KF ring formation. Wilson disease, hepatolenticular degeneration, is a rare condition involving the widespread abnormal deposition of the cornea in tissues. It is caused by a deficiency of the ceruloplasmin, the major copper-carrying blood protein. Presentation is with liver disease, basal ganglia dysfunction, or psychiatric disturbance. A Kayser-Fleischer ring is present in a 95% of the patient with neurological signs and consists of brownish yellow zone of fine copper dusting in the peripheral descending membrane. So this is a very important line. You have to remember two things in this. There is a copper deposition in which layer of the cornea? Descent membrane. And another thing which is very important is that 95% of the with the neurological sign have a KF ring. This is best dissected on gonioscopy when subtle. The deposits are preferentially distributed in the vertical meridian and may disappear with penicillamine therapy. Anterior capsular sunflower cataract is seen in some patients. So, what are the characteristics of the Wilson's disease in the cornea? KF rings, and you can see the sunflower cataract. Very pathognomic. Lecithin, so you can see figure C, you can see the brownish golden KF ring. Lecithin cholesterol is transferase deficiency. Lecithin cholesterol is transferase deficiency, LCAT deficiency, is a disorder of the lipoprotein metabolism that has complete Norm disease with systemic manifestation including renal failure and partial fish eye disease, only corneal opacification. Both are both autosomal recessive. Gene LCAT keratopathy is characterized by numerous minute grayish dots throughout the stroma, often concentrated in the periphery in an arcus-like configuration. So what is it saying? That LCAT has two types: complete and partial. The partial one has the ocular features. Ocular features, what are these? There will be the grayish white dot in the periphery like an arcus-like configuration, concentrated in the periphery, but it can be present centrally as well. So you can see figure D with the LCAT deficiency. Next is an immunoprotein deposition. Diffuse or focal immunoprotein deposition is a relatively uncommon manifestation of the severe systemic disease, including multiple myeloma, Waldenstrom microglobulinemia, monoclonal gammopathy of unknown cause, some lymphoproliferative disorder, and leukemia. Corneal involvement may be the earlier manifestation. Band of punctate flake-like opacities are seen mostly at the level of the posterior stroma. Treatment is that of the underlying disease. Severe corneal involvement may require corneal transplantation. So basically it is saying that the immunoproteins are deposited in the cornea due to the systemic diseases. Tyrosinemia type 2. Tyrosinemia is cynemia, oculocutaneous tyrosinemia. Richner-Hanhart syndrome is a very rare autosomal recessive disease, gene TAT, in which an enzyme deficiency leads to an elevated plasma tyrosine level. Ocular involvement may occasionally be the presenting feature. Painful palmar and plantar hyperkeratotic lesion and variable CNS involvement are seen. A bilateral pseudodendritic keratitis with crystalline edge often begins in the childhood and can cause photophobia, watering, and redness. So one of the two important things is basically the tyrosinemia is basically the increase in the tyrosine level. And one other thing, it is one of the differential diagnosis of the herpes zoster keratitis because it formed the pseudodendrite keratitis that begin in childhood, and it can cause photophobia and watering and redness. And what are the systemic features? Palmar and plantar hyperkeratotic lesion and CNS involvement. Fabry disease. So Fabry disease is also very important. You have to remember it's gene. It is an X-linked lysosomal storage disease, and it also causes a hold pattern like keratopathy. Fabry disease is an X-linked lysosomal storage disorder caused by deficiency of the enzyme alpha-galactosidase A that leads to an abnormal accumulation of the glycolipid. So what is it saying? What is the deficiency? What is it? It is an X-linked disease. And what enzyme is deficient in it? Alpha-galactosidase A. And what will it accumulate? Glycolipid. All males with the gene develop the disease, and some heterozygous female female. Of course, if it is an X-linked disease, the most of the males are going to be affected. Systemic features include periodic burning pain in the extremities, uh, acroparesthesia, and GI tract angiokeratomas, cardiomyopathy, and renal disease. Ocular manifestation include wild to golden brown corneal in a vortex pattern, 75% that may be the first feature of the disease, facilitating early intervention. Wedge or spoke shaped posterior cataract, Fabry cataract, conjunctival vascular tortuosity, corkscrew vessel, and aneurysm formation, and retinal vascular tortuosity. So you can see figure 6.67. So A is showing the angiokeratomas. Angio means some blood vessels like formation and in a dot shaped pattern. And B is showing the vortex keratopathy like a hold pattern. C is showing the conjunctival vessel tortuosity and aneurysm. So you have to remember this pictures, and you have to remember what is associated with this disease, especially these three. Now we are going to study about the contact lenses. So basically the contact lenses are the lenses that is put onto the cornea for different use. It can be therapeutic, it can be optical, it can um, it can be to eliminate to protect the cornea from perforation to prevent complications. So therapeutic uses. The risk of fitting a contact lens to an already compromised eye are greater than with the lens wear for cosmetic reason. The benefit risk balance should be considered in each case individually with education and regular review to ensure early diagnosis and treatment of complication. The choice of lens type is dictated by the nature of the ocular pathology. So you have to remember there are certain advantages and the disadvantages of the contact lenses, and you have to think before putting the contact lens that either the benefits are more than the risk factor. So what are the optical benefits? Optical is basically when you are treating the eye with some refractive problem. You are giving a contact lens to the cornea because you want to decrease the refractive power of the eye. Optical indications are aimed at improving visual acuity when this cannot be achieved by spectacles in the following situation. Irregular astigmatism associated with keratoconus can be corrected with rigid contact lens after spectacle have failed and before corneal grafting becomes necessary. Patients with astigmatism following corneal grafting may also benefit. So that is a very important role because the spectacles are failing and they are not giving you the complete correction. So you are giving the contact lens for the irregular astigmatism. Next is superficial corneal irregularities can be neutralized by rigid contact lens, which can provide a smoother, optically more regular surface. Visual acuity can only be substantially improved if irregularities are not too severe. Anisometropia, in which the binocular vision cannot be achieved by spectacles due to anisoconia, such as may occur following monoocular cataracts with high refractive error correction. So anisometropia is basically there is a difference in the refractive power of the two eyes. Like if you put on the glasses of this one, the size of the image can be decrease or increase. So with the contact lens, there is no such problem. So we can give contact lenses in this case. Next important advantages of the contact lenses is promotion of the epithelial healing. Persistent epithelial defects often heal if the regenerating corneal epithelium is protected from the constant dropping of the lids, allowing the development of the hemidesmosomal attachment to the basement membrane. So one of the things is when there is a persistent epithelial defect, we give the bandage contact lens because it protects the eye from rubbing against the eyelid. So it will allow the hemidesmosome to attach to the basement membrane. Recurrent corneal erosion associated with basement membrane dystrophy may require long-term contact lens wear to reduce the recurrence rate. In post-traumatic cases, lens wear can be usually discontinued after few weeks. Lens wear can also improve comfort. So, in recurrent erosion syndrome, the pathophysiology is the same. Pain relief. Bullous keratopathy can be managed with the bandaged soft lenses that relieve pain by protecting the exposed corneal nerve ending from shearing forces of the lid during blinking. The lens may also flatten bullae into diffuse fine epithelial cyst. So in bullous keratopathy, there are two things that are giving the relief. One is that in a case of a ruptured bullae, there will be the exposed nerve ending, and what bandaged contact lens do is it prevent it from rubbing against the lid. And second is that different bullae are then suppressed and they are becoming a fine epithelial cyst. Filamentary keratopathy resistant to topical treatment will usually achieve some relief from the soft contact lens, where other indications include thigh and superficial punctate keratitis and protection of the corneal epithelium from aberrant lashes in trichiasis. They can also be used as a temporary easing measure in entropion prior to definitive surgery. Preservative of the corneal integrity. So fourth is basically you have to preserve the corneal integrity. A desmatocele can be temporarily kept with a tight fitting large diameter soft or scleral lens to prevent perforation and encourage healing. Splinting and apposition of the edges of a small corneal wound can be achieved by means of a contact lens. Slightly larger perforation can be sealed with the glue following insertion of the bandaged contact lens to protect the glue and prevent irritation of the lid from the glue irregular surface. So basically in case of a corneal perforation, there is very small perforation, we can put the BCL. If there is a slightly larger perforation, we can put the glue and then put the BCL in it. Miscellaneous indication: ptosis probes to support the upper lid in patient with ocular myopathies, maintenance of the fornices to prevent symblepharon formation in cicatrization, trising conjunctivitis, drug delivery enhancement by hydrogel lens imbued with topical medication as an occasional indication. So these are just a new type of indications for the contact lenses. So what are the complications of the contact lenses? Mechanical and hypoxic keratitis. Insufficient pathogenesis, insufficient oxygen transmission through the lens. A tightly fitting contact lens that does not move with blinking will impair tear circulation under the lens. This is exacerbated by the lid closure if the lens is worn during the sleep. Hypoxia leads to anaerobic metabolism and lactic acidosis that inhibit the normal barrier and puff mechanism of the cornea. So basically the oxygen is supplied by the tears. So what happens if the contact lens is very tightly fitted against the cornea? It can cause the decrease in the tear film to flow through the contact lens, and it can cause hypoxia. Superficial punctate keratitis is a very common complication. The pattern may give a clue as to etiology. For example, staining at 3 and 9 o'clock position is associated with incomplete blinking and drying in the rigid lens wear. The tight lens syndrome is characterized by indentation and staining of the conjunctival epithelium in a ring around the cornea. So what is a tight lens syndrome? So basically around the limbus there will be small indentation of the cornea, as well as there will be the staining of the conjunctival epithelium in the ring shape pattern. Acute hypoxia is characterized by epithelial microcyst and necrosis and endothelial blebs. Very painful macroerosion can develop several hours after the lens are removed following a period of overwear. Chronic hypoxia may result in vascularization and lipid deposition. Superficial peripheral neovascularization of less than 1.5 mm is common in myopic contact lens wear and can be monitored. Treatment would depend on the cause but may involve increasing oxygen permeability by refitting with a thinner lens, gas permeable rigid lens, and a silicone hydrogel soft lens. modifying lens fit to increase movement and reducing lens time wear. So we can change the type of the lens that can be wear, and we can change the size, and we can reduce the time. So let's see figure 7.68a and b. Complication of a contact lens where A is an epithelial microcyst in acute hypoxia, B is a planus formation from chronic hypoxia, C is showing vascularization and scarring in chronic toxic keratitis, and D is showing the acute bacterial keratitis with vascularization. Immune response, hypersensitivity keratitis. A hypersensitivity response to bacterial antigen or the chemicals used in the lens care can lead to the development of sterile marginal corneal infiltrate. The mechanism is thought to be similar to the marginal keratitis. So basically what happens is there is a response to a bacterial antigen or chemical used in lens care, so it can lead to the marginal corneal infiltrate. Signs are the mildly red eye associated with infiltrate, often marginally located with no or minimal epithelial defect. Treatment involves cessation of the lens wear until resolution occurs. Topical antibiotics and steroid may be used in some cases, but if the diagnosis is uncertain, treatment should be that of a bacterial keratitis. Toxic keratitis. Acute chemical injury can be caused by inadvertently placing a contact lens on the eye without first neutralizing toxic cleaning agents such as hydrogen peroxide. Chronic toxicity can result from the long-term exposure to disinfecting preservatives such as thiomersal and benzalkonium chloride. So basically it is a toxic keratitis is due to a chemical injury because of the certain toxins that are used in the contact lens care, such as hydrogen peroxide, thiomersal, and benzalkonium. Signs are acute pain, redness, and chemosis on lens insertion, which may take 48 hours to resolve completely. Vascularization and scarring of the cornea and limbal conjunctiva. In chronic cases, treatment may involve switching to daily disposable lenses or using a non-preserved disinfectant such as hydrogen peroxide. Suppurative keratitis. Contact lens wear is the greatest risk factor for the development of bacterial keratitis. The risk is probably least for rigid contact lenses. Bacteria in the tear film are normally unable to bind to corneal epithelium, but following an operation and in association with hypoxia, they can attach and invade the epithelium. Microorganism may also be introduced onto the corneal surface by poor lens hygiene and use the tap water for rinsing. So basically there are multiple mechanisms that is involved in the case of a contact lens associated with bacterial keratitis. Basically the cornea get abraded by the contact lenses and it causes the invasion of the bacteria easy, and certain contact lens solution can also introduce bacteria, and following hypoxia it can also cause bacterial keratitis. Next is contact lens associated giant papillary conjunctivitis. We have discussed it in the conjunctiva. So that's it for the cornea part 19. See you in the next lecture.